Good morning, everyone. It's an honor and a pleasure to kick off the ALS Association Greater New York Chapter's Education and Resource Summit 2023 this morning. I'm introducing Dr. Shan Chen. Dr. Sarah Chen is currently an associate professor in the Department of Neurology at Rutgers University Robert Wood Johnson Medical School. She did her medical school training in Beijing University Medical School in China, and then obtained her PhD at Columbia University in neuroscience and neuropharmacology. She then finished her residency training at the New Jersey Neuroscience Institute at the JFK Medical Center of Seton Hall University and fellowship training in the Johns Hopkins Medical Institute in neuromuscular disorders. She joined Rutgers as a faculty member in 2011. She is currently the director of the EMG Laboratory and Peripheral Neuropathy Program. Her clinical research interests focus on autoimmune neuropathy, neuropathic pain, ALS, and myasthenia gravis. She is actively training many of our patients in ALS. Today, Dr. Chen will address pharmacological therapies in ALS. She'll take questions at the end of her presentation, so please type in any questions into the Q&A on the bottom of your screen. Welcome, Dr. Chen.
Thank you. Thank you for the introduction. Can you see my talk?
You need to share your screen.
Share screen, yes. Share. Can you see my talk now?
Looks good.
Okay, so good morning, everyone. Let's see, so since I'm the first one to talk today, welcome to the talk, and I just want to start with some general information of ALS. We know the incidence of ALS is pretty rare, 1.6 per 100,000 US people, and prevalence is 9.9 per 100,000. It's about 31,843 Americans are living with ALS, according to the estimate from CDC in 2017. And increasing age and male gender are two major risk factors. So there are other risk factors too. Everybody can get it, but then there are 10% of ALS has a genetic etiologies, and that means they inherited the disease from mutations from their parents. And there are other environmental or lifestyle factors such as military service, traumatic head injuries, electrical shock, and excessive exercise, some exposure to the toxic chemicals, pesticide, viral infections, smokings. And so the main cause of ALS is the motor neuron degeneration. So think about when we want to move our muscle, and the motor neurons in the brain and spinal cord has to activate, and through this axons to the muscles through neuromuscular junctions. And if the motor neurons is degenerating, so the muscle become denervated and become atrophic and weak. So the clinical hallmark of ALS is progressive motor deficit. However, it's very clinical heterogeneous disease and with very variable initial symptoms. Some of them are limb onset, which account for 60%, usually asymmetrical, either upper limb or lower limb, and 30% are bulbar onset, means they presented with dysarthria or dysphagia, means trouble speaking or swallowing. And some of them are rapid onset ALS. And so clinically, they're a combination of the upper motor neuron and lower motor neuron involvement. So what are the findings of lower motor neurons? Weakness, atrophy, and fasciculations. Probably most people with ALS experience. These findings are from muscle denervation. And there are also upper motor neuron findings with hyperreflexia and spasticities. Those are when you see the doctors, they check your tones, they check your reflexes. Those findings are a sign of upper motor neuron degeneration, especially the motor strip or lateral spinal cord. How do we diagnose ALS? There's no a single laboratory or biological markers. So over the years, the expert developed ALS criteria. Its consensus guideline for the diagnosis, first established in 1994 and revised in 2000, is really combined all the clinical examination, EMG nerve conduction studies, and also laboratory testing to rule out other mimics. And there's also you probably also often hear from your healthcare providers about this ALS FRS scale, which I always have to tell them, this is a functional rating scale. It's a questionnaire based, and we measure 12 functions, each score from 0 to 4 points. From 0 has no ability to 4 is normal. And the lower the ALS FRS-R is, the more functional loss that the patient has. So this is very helpful to monitor the progression of the disease, as well as provide a tool for clinical trial and clinical research. So this is a little complicated, algorithm to describe how we diagnose when you say possible ALS, probable ALS, or definite ALS. It's both for staging of ALS as well as for clinical trial and clinical research. Depends on how many regions of the weakness you have and how many regions of upper motor neuron signs you have, and whether you have EMG, evidence of the acute denervation, or whether you have other identified genes associated with ALS. So, and next we're going to move on to the mechanism of ALS. So we still don't know what causes it, but there are many pathogenesis pathways. So I listed all here with different colors just to highlight there are multiple pathways are the scientist has found to be implicated in the pathogenesis. And this is even a little bit more complicated. I'm sure the future talks today or tomorrow will address some of this genetics and also the research. And so over the past 2 decades, more than 50 drugs have shown the efficacy in the preclinical animal models. However, when we do the clinical trials, and many of medications shown efficacy in the animal models failed. So still no cure, and no drugs could reverse the ALS progression. So this has to be really clear to every patient. There's no drugs could reverse the progression. All the medication we have so far will just slow the progression or treat the symptoms, like I show here. So there are 2 categories of pharmacological therapies. One category is disease-modifying therapy, and another one is the symptomatic treatment. So for longest time, we only have 1 Riluzole, and now we have 2 and plus the Tofersen, so totally 4 now. And the disease-modifying therapy means they can reduce the damage to motor neurons, prolong survival, or slow the decline in daily functions, or increase the time to the need for tracheostomy or permanent system ventilation. So there are different measurements when the scientists design the clinical trials. For symptomatic treatment is that even though these treatments are not really targeting the ALS, the disease, however, they're going to enhance the quality of life and also makes the patients more comfortable. And we're going to talk both categories in this talk. So disease-modifying therapies. So Riluzole is the first one, also called Rilutech, approved in 1995. Edaravone, also called Radicava, the IV form approved in May 2017, and oral solutions approved in May of 2022. The PB-TURSO, also called Riluzole, approved September of last year. And the very new one is the Tofersen, is approved April of 2023, which is specifically for SOD1 ALS. So first, we're going to start with the Riluzole. And for all patients living with ALS, we recommend treatment with Riluzole as the first therapy. And the mechanism of action, simply put, is glutamate release inhibitor. Basically, it's reduce the glutamate toxicity to the motor neurons. And the benefit is modest. Based on 2 studies, and in a prospective double-blind placebo-controlled trial in 155 patients with ALS, at 12-month survival, the patient received Riluzole at pretty high dose, 100 milligram daily, compared to control, is 74% with Riluzole and 58% with placebo. So there's benefit, but it's modest. And for the subset of patients with bulbar onset, there's even greater advantage for survival. So at 12 months, it's 73% versus 35%, because we know some of the bulbar onset ALS may progress a little bit faster. And in another larger follow-up trial, there are 59 patients, and also shows like 57 versus 50% of survival, both survival without tracheotomy advantage. However, the functional measures did not differ significantly among the groups. So these are the 2 trials we based on. Based on the trials, the indications really for patient with ALS with definite and probable, means a little bit more advanced ALS, and symptom onset less than 5 years. The vital capacity, the breathing function measurement, vital capacity above 60%, and patient has no tracheotomy. However, although there's no data support, we always use the Riluzole even for the patient with suspected or possible ALS by ALS criteria, as I described in the beginning, and even for more than 5 years, or vital capacity less than 60%. And a tracheotomy, usually we don't, but then if it's just for prevention of aspiration only, and then we still recommend Riluzole. What about, so Riluzole at 100 milligram per day, prolonged stage 4, means when they have a little bit lower vital capacities predicted, or they already have the feeding tube, instead of slow the entire disease course or prolong 2 or 3, it may prolong the last stage of the ALS. And also the greater benefit at early stage, before the occurrence of significant motor neuron degeneration, like all the other medication, the earlier you start to receive the therapy, the better outcome. And the better prognosis in a recent study also shows a cumulative benefit. If you have a cumulative daily dose of Riluzole higher than 16,800 than other groups, therefore the long-term use is accumulative. So the recommended dosing is 50 milligram twice daily. There's a 3 formulation tablet suspension, also called Tiglutic, or the oral disintegrating film, also called Edaravone. So the mechanism is through the CYP 450 1A2. So sometimes they may have drug-drug interaction if the medication, or for example, caffeine also uses mechanism of metabolism. So they might potentially decrease the rate of the Riluzole elimination, therefore enhance the benefit. So what about the side effects? It's pretty well tolerated. the most significant side effects is just the GI or hepatic. And the most common side effect is asthenia or fatigue. We see some patients do get like more tired once they're on Riluzole. Some of them have dizziness or elevated in liver function test. And other side effects are pretty rare, like neutropenia, anaphylaxis, interstitial lung disease, or pneumonitis. So I want to say a little bit about liver function enzymes. So because like in the study, at least one ALT levels will be like above the upper limit of normal in about half of the patient in a patient with the Riluzole. And about 3 to 5 times of the upper limit normal is seen 8 and 2% of the patient respectively. Therefore, when you were started on the Riluzole, often we do the liver function test monthly for the first 3 months, and then every 3 months after. Just want to make sure the liver function enzyme is within normal limit, and often even if they're a little bit elevated, they're not indicating of the like liver damage, but rather it's reversible once we reduce the doses. And so now we move on to the second medication called Edaravone. It's a free radical scavenger. So it's thought to reduce oxidative stress, basically makes a more healthier environment for the motor neurons. And the benefit of this medication as slow function deterioration is really clearest in the patient with early ALS, as defined in the pivotal phase 3 trials. Therefore, we suggest this medication for all patients with ALS. And so these are the data. So for the efficacy trial, although initially the trial there's no statistically significant benefit for function of on the ALS-FRS score treatment compared to the placebo. However, when they do the subgroup analysis with early stage ALS, there is a significant benefit. We call it early stage ALS, this pivotal trial. So the summary of the result is that at 24 weeks, the ALS-FRS decline was 4.49 points less with this medication versus for placebo, or slowing about approximately 33%. So the data for early ALS is very clear. So how do we define this early ALS in the trial? Is definite or probable ALS at entry who has score of 2 or more on all items of this ALS-FRS, and also FVC of at least 80% at baseline, and the disease duration of 2 years or less. So this is also like a lot of patients get insurance typically approve of this based on this trial. So often a lot of patients get denied because like based on the trial, they said you need to have this disease duration of 2 years or less. So therefore, the early diagnosis is the key, and the early start on the treatment is also crucial. And also the study showed the less decline on the ALS assessment questionnaire, and open label study showed continued benefit even up to the 48 weeks. So we gave Edaravone at 16 milligram IV. So I'm sure some of you have take this IV formulation first, and now transition to oral suspension. Same dose, like to be taken in the morning after overnight fasting, and starters always daily dosing for 14 days, followed by 14 days off, and subsequent doses is daily dosing for 10 days within a 14-day period, and followed by 14 days off. So a little bit unusual dosing, but this is how they develop the trial. And so the side effect most common is that mostly for the IV, their injection site contusion, because they could be like port or PICC line, so they could have thrombosis, bleeding, or infection. And with the oral solution, it's pretty well tolerable. Some people complain of gait disturbances or some headaches, and very rarely they cause anaphylaxis, hypersensitivity, or erythema multiforme, which, like in our clinic, we didn't see much of these side effects. Edaravone also contain sodium bisulfite. Therefore, 5% of patients with asthma may have severe asthmatic reaction. So individuals without asthma are rarely affected. So often we ask the patient whether they have a history of asthma before they start this therapy. So the third medication, Riluzole, also called PB-TURSO, and it's a combination drug, and is a histone deacetylase inhibitor, and reduce the adaptive stress response in endoplasmic reticulum. And a lot of people take TATCA before this trial, this medication got approved. So this bile acid actually increased the threshold of cellular apoptosis by maintaining mitochondrial integration through reduced membrane permeability. So basically, it's reduced neural cell death. So this prolong the neuron survival. And we also suggest this medication for all patients with ALS. But a lot of initial treatment is limited by availability or very high cost. And so the efficacy data is shown, it has been shown to slow the clinical deterioration in patients with ALS. And there's a phase 2 trial, Centaur, of 137 patients with definite ALS who are within the 18 months of symptom onset. And this medication showed there's slower rate of decline on the ALS-FRS rating scale. However, there's no change in the biomarker of neurofilament, and also there's no change in time to death associated with the treatment, but there's a trend towards slower decline in vital capacity, means breathing, and also muscle strength. So the open label study up to 35 months, they randomized the medication, shows they have longer median time to tracheostomy and ventilation by 7.3 months, and also longer median time to first hospitalization and 6.5 months longer median survival. So it does provide both survival and like functional, slow the functional decline. And the phase 3 trials, which we were part of it, Phoenix, and just finished enrollment, and they're further assessing the efficacy and safety of this medication for 48 weeks in both US and Europe. So it's a powder containing 3 grams of sodium phenylbutyrate and 1 gram of pteroxodiol to be administered as suspension. You dissolve in 8 ounces of water, and you take orally or feeding tube once daily for 3 weeks, and then twice daily after. So most common side effects are diarrhea, abdominal pain, nausea, or upper respiratory tract infection. Most patients actually complain more like bitter taste, and so as you know, intolerable, but most people still take, they can use different ways to take it to make it a little bit more tolerable. And also it may cause fluid retention, should be used with caution in patients with sensitive to salt intake, such as patients with hypertension, the kidney disease, or heart failure. There's some drug-drug interaction, may affect the concentration if they share the same CYP 450. And so the last one we know is the Tofersen. So it's the pathological SOD ALS patient. So they have this SOD toxic proteins. They aggregate and cause the motor neuron death. And this is gene silencing therapy, like antisense oligonucleotide or ASO therapy. They actually downgrade or silence SOD by binding to these mRNA sequences and also reduce translation and subsequent protein expression. And the use is extremely beneficial in SMA, the spinal muscular atrophy, another type of inherited motor neuron. And now we see the benefit of the SOD1 ALS. So it's very, very exciting. And we suggest this therapy for patients with ALS associated with SOD pathogenic variants. So the patient with ALS has to be genetically proven to be SOD1 positive. And it's given intrathecally via LP over 12 weeks, reduce CSF SOD1 concentration. And the data shows they actually, although there's no change in baseline in this ALS-FRS functional rating scale in 28 weeks, but in 52 weeks, the treatment group was associated with a reduced progression in several measures, including slow decline in the ALS-FRS, vital capacity, and also grip strength in all patients treated. And there are more pronounced reductions in participants who started early start cohort. So it's a question when to start if the patient has no symptoms, has this genetic proven mutation. And then patients in this study continue to be actively followed to assess for longer term benefit. So how do we give it? It's a solution give intrathecally by lumbar puncture over 1 to 3 minutes. And dosing is 100 milligram in 15 ml, initially every 2 weeks, 14 days for 3 doses, and then every 28 days for maintenance therapy. So it is a little bit invasive therapy. And common side effect, which we don't have a lot of experience yet because it's just approved, including injection site pain, headache, fatigue, and arthralgia, means joint pain. And severe serious side effects include myositis, radiculitis, septic meningitis, elevated intracranial pressure. And so I just want to talk a little bit about B12 because a lot of patients come in with this question. So megadose B12, so it is offline therapy, it's not FDA approved. And there are data shows it might benefit from, they might prolong survival. So there's a phase 2 or 3 study of 373 patients with ALS in Japan. They report ultra high dose. The dose is 25 to or 50 milligram intramuscular injection twice per week. So usually when people take B12 supplements is 500 to 100 micrograms, so it's 1 milligram. So now you have 25 to 50 milligram IM injection. The study shows it's safe, is well tolerated, and with the trend towards clinical benefit. And subsequent study in phase 3 shows early stage ALS actually has slower functional decline compared to placebos. And so the score at week 16 of the randomized period was 1.97 point greater than with B12 than placebo. So it suggests beneficial, effect of treatment with ultra high dose of B12 injections. However, it's not FDA approved yet. So we're going to move on to the second category of therapy, symptomatic therapies, as most ALS patients experience. Aside from the muscle weakness, they might have dysarthria, means trouble speaking, difficulty breathing, muscle spasm, spasticity, and sialorrhea, means drooling, fatigue, thick mucus, pain, pseudobulbar effects, cognitive impairment, including frontotemporal dementia, psychological aspect, and sleeping problem. So most of the time when patients come to our ALS clinic once every 3 months, and we address all these symptoms through our team efforts. So we're gonna just briefly talk each one of them as much as we can. Everyone is like, every topic can be a talk by itself. So first of all, most people experience fatigue. 90% of the ALS reports fatigue. It could be due to hypoventilation. And actually, some of the fatigue can be associated with the medication they receive, such as Riluzole, the baclofen, tizanidine, the Beximol. So once that was identified as the side effects of medication, if you reduce the dose or take off the medication, the fatigue can be better. And modafinil is also can be empirically tried for fatigue. It has success in other fatigue from other disorders. So therefore, like, you know, sometimes we give modafinil for patient with fatigue with ALS. And also people try glucocorticoid, a 2 weeks trial of dexamethasone daily, or progesterone acetate can be tried for fatigue. Also, progesterone can be tried for like appetite enhancer. And the next symptom is muscle spasm. A lot of people experience muscle spasm, can be randomly occurring, can be quite disabling. So the doses is the medication we use is maxillitin, 150 milligram twice daily. In the trial with NEOs, they're 20% with ALS and muscle cramps, and found it actually can reduce from the mean baseline of 6 cramps per day to by about 2 cramps per day. So there's no serious side effects or QT prolongation over the 2-week treat period. So it's very tolerable, and side effects involve dizziness, nausea, tremor, falls, especially with higher doses. And in addition to maxillitin, we can also try anticonvulsant like Keppra, like Tegretol, or phenytoin or Dilantin. And also the quinine sulfate is very effective, but has a limited use due to the PT prolongation and also thrombocytopenia, therefore very limited use in the US. And other medications have been tried for cramps, including baclofen, the gabapentin, tizanidine, but their utility is also quite limited. So a lot of people have thick mucus, and it can be associated with sialorrhea and increased oral pharyngeal secretion. Therefore, it's very important to differentiate sialorrhea with increased secretion, because the treatment can be a little bit different. And there's no trials for any of the medications, and then the treatment involve increased fluid intake, mucolytic. There's medication, if they can cough, there's medication called N-acetylcysteine, 200 to 400 milligrams 3 times a day. And then if you put the humidifier, humidification of the air, or some cough augment with respiratory therapy or mechanical devices, can help the thick mucus. Pseudobulbar effects means emotional liabilities. Patient may have excessive laughing, crying, or yawning, secondary to the degeneration of the cortical bulbar tract. And the treatment to reduce this daily laughing, crying episode, and the combination drug Nuedexta was approved, 20 milligram of dextromethorphan with 10 milligram of quinidine, and the starting dose is 1 per day for 7 days, and increased to 1 twice a day. And also in clinical practice, we can try amitriptyline. Sometimes Nuedexta may not be approved by insurance. So the tricyclic antidepressant also helps, start with 10 milligram and can titrate up to 60 milligrams therapeutic dose taken at night. And some people can be even titrate up to 100 to 150 milligram at bedtime. For pseudobulbar effects, we can also try SSRI, selective serotonin reuptake inhibitors, such as fluvoxamine, 100 to 200 milligram daily. And sialorrhea drooling is very, very common, and can be also very disabling, and it's caused by the combination of facial muscle weakness and the reduced swallowing capability, called pseudo hypersalivation. So normally everybody swallow about like 2 liters of their saliva. So once you reduced capability to swallow, all this will just come out as a drooling. So the first line therapy we use is anticholinergic. The most trials done for drooling are done for non-ALS disorders such as Parkinson's and so forth. Therefore, we just empirically use this for ALS, very limited data on ALS salaria. So the therapies include atropine, 0.4 milligram every 4 to 6 hours, hyoscyamin, and there are different formulations, sustained release, fast acting oral, or even transdermal. And there's amitriptyline. So look here, the amitriptyline can both help the salaria as well as the pseudobulbar effects. So that's why, and also the pain. So that's one of my favorite for a symptomatic treatment for ALS. And also glycopyrrolate, 1 milligram 3 times a day. And scopolamine transdermal is a patch. You use the patch, it's 1.5 milligram. You can apply behind the ear. And after 3 years, you can remove this old patch and replace it with a new one. And it works for some patients. So if none of this pharmacological therapy works, we can also try Botox injection into salivary gland, either parotid or submandibular. However, the caution is that they may be associated with a prolonged dysphagia. So therefore, if the patient has dysphagia, if they also try to avoid the feeding tube, so like really has to be used in caution. And also in our clinical practice, if they still fail Botox, they can also try the low dose radiation therapy by the radiation oncologist. So next, we're going to talk about the symptoms of spasticity. So very, very common because of upper motor neuron degeneration. And the first line, we often use baclofen or tizanidine, although there's not much evidence suggesting they have efficacy. And they're both central acting, means they work on the brain. Actually, even though it's spasticity of the muscle, they actually act on the intracranially. So the efficacy is comparable. However, the baclofen may cause weakness or fatigue, and tizanidine more likely cause dry mouth or elevated liver function test. So just monitor and then see which one you're tolerable. If you don't tolerate this one, we try the other ones, or vice versa, or the combination. And if they both do not work, and we can try the Botox injection. For the spasticity, however, the use is mostly for other upper motor neuron disease like stroke or MS, and then in the ALS is quite limited for spasticity just because it might increase the weakness. And some people will try baclofen pump, but very, very rarely we try. It's usually used for very subset of the patient who has severe spasticity, especially with upper motor neuron, only the motor neuron disease. And recent data suggesting cannabinoid or nabiximols can be benefit from spasticity. So it's a combination of THC with CBD spray. So they can reduce the motor neuron disease related spasticity in a phase 3 trial, phase 2 trials, and the phase 3 trials is currently recruiting. So next symptoms of ALS is pain. The pain in ALS patients is multifactorial. So it can be secondary to reduced mobility, the muscle spasm, the cramps, the spasticity, or other comorbid conditions. Especially reduced mobility, they can cause the musculoskeletal pain, as well as pressure-induced skin or soft tissue injuries. There's very little data on how to manage the pain in the ALS. So basically, the clinician just either use analgesics or anti-inflammatory drugs like Advil, Tylenol, or opioids. And actually, attentive nursing care is very important. Frequent change in their positions can help prevent skin breakdown and joint stiffness in patients with reduced mobilities. And we provide to our patient a lot of necessary assisted devices, such as special mattresses, the pillows, the custom fitted wheelchair also help prevent the pain. Sleep problems, insomnia is very common and also multifactorial and can be secondary to other problems associated with ALS, such as anxiety, depression, dysphagia, dyspnea, especially dyspnea because they couldn't breathe. They kind of crave for the oxygen, and then they disrupt their sleep patterns. And they have an ability to change their positions during sleep also is disrupting. And so and the use is NPPV. So often we use sedatives very carefully, very cautiously, and there's no trial like on the insomnia in ALS, and then often you just try very low dose Ambien, amitriptyline, mirtazapine. I really try like the other like chlorohydrate, diphenhydramine, or fluorazepam. So basically it's what we do for insomnia in other conditions, but we use kind of cautiously because we don't want to suppress breathing. So these are pretty much a kind of like a whole like all the therapies like we commonly use, but every patient is like different. It's like we definitely use individual based therapies, depends on the stage of the ALS and then the symptoms each patient has. So the bottom line is the multidisciplinary ALS clinic is the key, and also the this, when you come to this, like get all the informations and then you share the informations, you support each others, and then which is really help every patient. So yeah, anybody have questions?
Yes. Wow. Thank you, Dr. Chen. Thank you for all of that information. We're all richer for that, that's for sure. There are some questions. One of them is, what does it mean to take Riluzole when the onset of symptoms has been more than 5 years ago? Is it still helpful to continue?
Not according to the trial, but then it's so there's no trials on patient with that, so we just kind of empirically like think it will be benefit, so why not, right? So why not benefit, especially benefit the stage 4 rather than 2 or 3. So I think like we just still recommend it. So usually we don't recommend if they start the the tracheotomy. So I think there's no data, but we still recommend it.
Thank you. Of the 3 medications that you talked about at the beginning, the Riluzole, the Edaravone, and the Rilivrio, is it safe to take them all together?
It is safe, and then usually I tell my patient is there's no data on the combination trials. However, a lot of patients enrolled in the trial of the Riluzole, they didn't exclude the patient on Riluzole, and then most people are on Riluzole. And so what I tell patients that because they target the ALS from different mechanism of action, it is safe, and it's fine to take all 3. And we do have a lot of patients take all 3.
Okay, thank you. Another question. Does the same dosage apply to those with bulbar ALS for Rilutech and Ticlutech?
Yes, it's the same dose.
Thank you. There is a lot of excitement about the new drug that was just approved, Tofersen, when it can be taken by so few people. Does it have other implications for the future?
Hopefully yes, but it's like genetic. So it's a gene silencing therapy. I would not think it will work if you don't have SOD1 because it's really gene targeting therapy because it's reduced SOD1 concentration, like it really specifically target SOD1 mRNA. So therefore, I would not think so. However, maybe the talks in the afternoon or tomorrow will address that.
Okay. Can people who have PLS or the other subtypes of ALS take those medications?
That's very good questions. The answer is we don't have the data, we don't have the trial on those. At least I didn't come across that. And however, what do you call it? Especially Riluzole, I think we still recommend Riluzole. And the other ones, I would be very doubtful that insurance company want to reimburse if you have PLS, not ALS. Yeah.
Okay. Another question says, please discuss the practical aspects of taking these drugs. How are they administered at home?
Which one?
I'm guessing that this person meant the Riluzole and the Edaravone.
Yeah, so there, I think I put the doses there, so you can safely do either the orally, the film is you just put it in the mouth, and so for the Riluzole, just pour in the water and then you drink it.
Mhm.
Is that right, Mary Ann? You can help me.
Yeah, you are right. Yes.
Yeah. So, for a lot of the questions, you can always consult your center or consult the chapter, and then we'll have answer for you.
Absolutely. Are there any final questions for Dr. Chen? Okay. Dr. Chen, thank you so much. Thank you for this very important information. I want to invite everyone to tune in again at 11:15 to discuss respiratory care with Josie Pelzer.
Thank you. Thank you for inviting me.
Thank you.